Our next presenter is Dr. Amanda Risser. She is an addiction physician and family doctor working at Central City Concern, where she's the senior medical director of substance use disorder services, providing a continuum of care to folks with substance use disorders, including withdrawal management services, outpatient behavioral and medication treatment, supporting housing, residential services for women who are parenting infants and young children. Amanda has also provided integrated treatment for substance use disorders in primary care settings such as FQHCs, and as part of a team that brought on site prenatal, intrapartum, postpartum, neonatal, and well baby care to women in treatment at an opiate treatment program as part of the Health Share supported Project Nurture. Pretty impressive. This morning, she's going to share some pearls covering everything from treatment engagement to withdrawal management. Let's listen to Dr. Amanda Risser.
All right. Thanks you all so much for inviting me to participate in this. I'm going to tackle alcohol use disorder diagnosis, medications, and I'm going to focus on ambulatory withdrawal management, which hopefully will be helpful to you generally and really specifically in this time where we're trying to manage folks in creative ways. And I know that Kyle and Matt Chan are going to be talking a little bit later about SBIRT, screening and then brief interventions, which is a really powerful tool to support folks in primary care in being identified as folks potentially at risk, and then providing what is proven to be effective interventions just in and of itself by having these brief interventions. So I'm really looking forward to hearing more about that. So I don't have anything to disclose in terms of any ways that my presentation may be biased by big pharma or other sources of income, but I do want y'all to know that I'm a addiction physician and family doctor who really came to addiction medicine through opiate use disorder treatment. And I'm really grounded in that. And I came to that work through being a buprenorphine prescriber pretty much from residency, from my second year of residency. So I've been doing that forever. And really, it's only been in the last 5 years or so that I've worked a lot harder at being a better physician to folks with alcohol use disorder. And part of that is I find it hard to treat. I find it difficult to really provide folks with the level of support that they need. And I think there's a lot to that, and we can explore that together maybe in the Q&A, but alcohol use is very prevalent. It's very socially accepted. It's something that is, sometimes encouraged. I'm thinking about times when, even in the last 3 months where, there's a lot of jokes about, getting through homeschooling your kids for during shelter in place, one sip at a time, and everybody laughs about that. And I'm really seeing in my work at Hooper Detox like the dark side of that. Folks isolated at home, feeling stressed and anxious, and really turning to alcohol as a way to get through that and getting pretty sick from it. So anyway, we'll muddle through this together. I've learned a lot in the last few years about this, so hopefully I can share some of my pearls. So I think the thing that's also really challenging, but also exciting about alcohol use disorder is that people with alcohol use disorder, a lot like most use disorders, they present everywhere. So there's lots of different ways that you can gather information about your patients when you're in primary care, because you're getting notifications that they're showing up in the ER with trauma. That might be a clue. You get their screening results. They get admitted to the hospital and maybe unexpected for a different reason and unexpectedly go through withdrawal, and you're given information about how their use disorder might be more severe than you thought. They might get a warm handoff to a behavioral health specialist in your primary care office and discuss their alcohol use in a way that maybe you weren't aware of. So there, if your eyes and ears and um, clinical brain is attuned to this, you often have the input you need to help make that diagnosis. And it also, gives you a lot of opportunities to start a conversation about alcohol use disorder. And for somebody who may not be all that interested in acknowledging that they have a use disorder, exploring whether or not they have a use disorder, it gives you a lot of different moments where you might gently engage in some motivational interviewing to identify, maybe somebody has a goal that's not related to alcohol use, but maybe they want their hypertension to be better controlled, and that's like you're in. Or maybe somebody's not sleeping well, and that's something that you can gently explore with them. So that was really where I found the most fruit in my primary practice, and even today in my my addiction practice. Um, and just as an aside, I always was concerned that I wasn't very good at motivational interviewing because it felt kind of like a thing. It felt like, oh gosh, I need to, go to like hours of training, and I need to get good at this this technique because it's really important. It's proven. And the more I learned about it, the more I saw how motivational interviewing is really the bread and butter of primary care. If you're a halfway decent primary care provider, you're doing motivational interviewing all day, every day. And then, sure, learn more about it so you can identify it and practice and get better at it. But I always felt like my lack of knowledge was kind of a barrier. It's like, oh, if only I was better at motivational interviewing, my patients would be doing better. It's like, actually, no, I'm pretty good at it, and here are some pathways to getting better. So it's just a little pep talk. Something we know about engagement and treatment from our understanding of how folks initiate, become engaged in treatment is that folks generally are better engaged when they're in a behavioral health setting. And that's probably because of the motivation that brings a person to that behavioral health setting, and then also perhaps due to the expertise that the folks in behavioral health settings apply to patients with alcohol use disorder. Also, there's a lot of folks that end up getting referred to behavioral health settings through criminal justice, especially through DUI diversion, like mandatory treatment in order to get their license back, et cetera. And so that is a place where a lot of folks land if they have a bad enough alcohol use disorder that they've had some legal consequences from it. I work a lot in a withdrawal management setting, and we initiate treatment for tons of folks with alcohol use disorder. We safely get them through a withdrawal management episode. We safely shepherd them through the sometimes very, very challenging week or so of severe withdrawal. But then it's often hard for us to get folks to a next step, and there's lots of reasons for that. There's not enough treatment in our state. We're pretty bad in terms of our rates of availability of treatment. And then, folks have varying motivation, so it's not uncommon for us to see folks more than once in the withdrawal management setting. And it's not uncommon for folks to either leave because that's their preference or not be connected to the warm handoff of treatment that they desire because it's not available to them. So there's lots of opportunities, and we're all part of this, which is the bottom line. Folks like me who do specialty care and folks like you who are in primary care, we all share this work. I wanted to just highlight what we've learned over the past few months, since we have been under stay-at-home orders since March. There is some evidence that alcohol sales in liquor stores, et cetera, are above and beyond what you'd expect from the decreased sales in restaurants and bars. And there's a lot of popular media and some emerging research that characterizes that. I know that anecdotally, the stories I'm hearing over and over again from folks that I'm admitting to withdrawal management is, I was doing okay, and then I was at home all the time, or I lost my job, or I'm at home with, the person I'm in kind of an unhealthy relationship with, or you know, um, I was just about to make a transition into intensive outpatient treatment and then everything shut down. Oh, I don't have access to my meetings. I'm hearing a lot of stories about folks drinking getting worse and their use disorders get worsening or relapsing into use, turning to use during this time. So um, I think that's there, and then there's some good evidence that shows that during um, the 9/11 in New York City, that first responders after that trauma and difficulty, that a lot of folks there had elevated rates of alcohol use in the years after that, even folks that weren't directly involved with that. And there's also studies of folks that were involved in a smaller, but pretty, still pretty serious outbreak of SARS in Asia, that folks that were quarantined at home and first responders had higher rates of alcohol use disorders in the years after that as well. So I think we've got to kind of get ready for the problem that's existing in the immediate and short term here, and then also some future problems coming out. I mean, certainly we know that recessions and economic downturns are associated with alcohol use as well. Um, so I think one last thing to say about this is that there is some evidence that folks are buying larger quantities of cheaper alcohol than prior to this moment. So, something that's really called for, we're really called even before our pandemic and all the things that are happening all at the same time right now. We were really called to do better. And we developed as a state a health improvement plan that targeted lots of different areas of this. There's good evidence that shows that if we have a state alcohol beverage control program that's functional and that is controlling price and availability, that there's less alcohol use disorder. And there's also really the need to build capacity, especially now among culturally specific organizations. I think there's ways that we know that access has been denied to folks from different groups in our society. Treatment is not accessible to all in the same way. We don't have low barrier access in all places. We need to incentivize the use of evidence-based low barrier treatment. We need to increase our rates of screening and referral, even though we're doing a lot with ESPERT, which we'll learn more about later today. We need to restrict alcohol marketing, promotion, and retail, and that because that has been shown in multiple public health studies to decrease use and the complications of use. And again, how many times a day do we already see marketing around alcohol use? And especially now that, in some ways sales are widening because there's like takeaway cocktails and there's in some communities across the country. And I think even, I see people walking down my street with beers several times a week, and this is I think that there's just an increasing acceptability of at-home drinking given that we're staying at home. So I wanted to review the DSM-5 criteria for alcohol use disorder. I learned, I think, the DSM-4 criteria for alcohol use disorder when I was training, and it took me a while to kind of unlearn that. And embedded in the DSM-5 criteria, it's first of all a lot simpler and more straightforward, and then also it uses more supportive terminology. Like there used to be a way of characterizing whether or not somebody was abusing alcohol, and we've learned through linguistic research that the word abuse helps connote and kind of support stigma for folks that are using substances. So we're trying to ground ourselves in the biopsychosocial model of substance use disorders, approaching them more like a chronic disease, really grounding them in neurobiology, and evidence-based treatments, but also, of course, understanding all the different ways that use disorders affect people socially and interpersonally. But I really love the DSM-5 diagnostic criteria because it's straightforward and it's clear. So there's 11 things there, and the more that are positive for you, the worse your use disorder is. And it's all about craving, compulsion, lack of control, and then consequences. And for alcohol use disorder, you don't always have to have dependence, which means you have a withdrawal syndrome with cessation of use, but most people, by the time they have a severe use disorder, do have that. But you start gathering data from your patients about what kind of role obligations are you not fulfilling? Have you lost a job? Are you doing poorly in school? Are you getting along poorly with your close relationships? Have you given up recreational activities you used to enjoy? Are you spending most of your time drinking, being intoxicated, or recovering from use? Are you using in situations that are physically hazardous? Are you driving? Are you getting into accidents? Are you, getting into altercations, etc.? Are you using even though it's affecting your blood pressure, worsening your diabetes, and then affecting your liver? Just as an anecdote, it is so common for me one of the questions I always ask everybody is, what physical consequences have you had from your alcohol use? And it's not always that everybody sees a link between maybe their alcohol use and their high blood pressure, or their alcohol use and their worsening diabetes, or the alcohol use and that ankle fracture they had. It's not always clear to them. But something that I often say here is that my doctor told me that it's surprising my liver is not worse than it is. And I think I probably hear that 2 or 3 times a week. So it makes me wonder, it makes me kind of reflect, how many times did I tell somebody that? Be like, wow, you're drinking a lot, your liver's not so bad. And then what kind of message do we give people when we tell them that, like, well, at least you haven't ruined your liver? I mean, livers are pretty resilient. So I think it might be more supportive of patients and a better motivational interviewing tool to maybe focus on other consequences that they might have with their alcohol use. Because honestly, livers do generally recover. It's really, I don't see, except for folks that end up with devastating disease from pancreatitis or acute alcoholic hepatitis, that happens for sure. But the average drinker doesn't really get into terrible trouble with their livers until years down the line. So just another little pearl that maybe when folks come to withdrawal management, they also often tell me that their doctors told them that they're not as sick as they expected given their level of drinking. Maybe that's not a helpful message. So if you have at least 2 of these symptoms in the last year, you have a mild disorder, 2 to 3 of a moderate disorder, and 4 to 5 you have a severe disorder. And Matt and Kyle will talk about, when you're doing SBIRT, like what you do next. So generally, I don't see people in withdrawal management unless they have a severe disorder. They don't generally need withdrawal management unless they have a severe disorder. Moderate, I may see sometimes, and that may be some folks that we can support through outpatient withdrawal management. Mild disorders, I think, is worth a brief intervention and a chance to chat about maybe ways that their drinking could be problematic to them. All right. I wanted to talk a little bit about initiation and engagement. This is a measurement that we are using to explore ways that, of measuring quality, right? So initiation means somebody who has received treatment with 14 days of diagnosis. And then, so those are people who have received treatment. That's the numerator, and the denominator are members with a new diagnosis. So you drop the diagnosis of alcohol use disorder. And I think that actually is supposed to, I didn't catch that, but it's supposed to be AUD-DX, not AOD. And then in the numerator, it's treatment. And then engagement is, again, the same denominator, members with new AUD diagnosis, and the numerator is folks that have received treatment within 34 days of the initiation. So sometimes, that happens on the same day or close together. So like if you start treatment and then provide treatment on the same day, that can still be acceptable. And some of this is stuff that is not necessarily in the realm of the average primary care provider, because folks that there's ways that we conceptualize episodes of treatment, episodes of care when we're engaging the behavioral health benefit compared to just physical health. But I think a simple way to think of it is like, you make the diagnosis, how quickly do you get folks involved in treatment, and do they show up? That's what we're looking at here. And it turns out we're not doing a great job. So, these are some baseline data that Stacy was kind enough to share with me, I think from HealthShare. So what we see here, this is a very busy slide. It's hard to see. You'll be able to kind of look at it in more detail if you want to with the slides. But I think the main thing to know is that our initiation rates are, the best we're doing is in behavioral health, and it's 54%. So even in a place where somebody, you're getting somebody in front of like the best experts to address alcohol use disorder, only half of them are initiating treatment. Kind of some interesting things is that in the emergency department, it's 12%. In inpatient, it says 100%, and that's, I think, a little bit misleading, because I think that's usually when folks are diagnosed with alcohol use disorder in inpatient settings. They're almost always getting treated in some way, and that's how it's measured. And Stacy can kind of help us understand this a little bit more. Every time I look at the slide, I come up with more questions. But I think the bottom line is basically like, we're not doing a great job. If we average up how everybody's doing across different settings like detox or withdrawal management, emergency department, inpatient, outpatient, and outpatient. So the primary care office, that's the bottom one, is that the initiation rate for treatment and the engagement rate are really poor. So 11.5 and 2.9%. So if we're going to improve those numbers, we need to be better at diagnosing alcohol use disorder, starting evidence-based treatments, and starting some behavioral health support, and documenting that appropriately. So what are the ways that we can improve how we provide treatment to patients who have received the diagnosis of alcohol use disorder in a primary care setting? Well, one of the ways we can do that is by providing patients with medication. Turns out these medications are not widely utilized, or utilized as much as they probably could be. And part of that is that we're not all that familiar with these medications. Another part of it is how the patient experience of using them is. So I'm going to go through these 4. Again, it's another very dense slide, and I'm also going to mention a few that are not on there that you may have heard of, and talk a little bit about the role of medications to treat alcohol use disorder in the primary care setting. So I'm going to start with the first medication on that table there, acamprosate. So acamprosate is already a little bit tricky because you can see that the dosing there is 666 milligrams 3 times a day. A camprosate is meant to be initiated after somebody goes through withdrawal. It has been shown to help with engagement and cessation of drinking. And there's not excellent data to support it, but one of the studies that's summarized in the AHRQ publication that this table is from shows that the number needed to treat is 12. Which is actually pretty good because, if you think about other medications that you use every day in primary care, like medications to provide treatment for hypertension or diabetes, the number needed to treat for some of those medications to prevent a significant outcome, negative outcome, is in the 20s to 30s. So it's interesting to me that we feel compelled to and are measured on our provision of diabetes medication and hypertensive medications to patients, but we don't know much about these medications. So for camprosate, the main adverse effects are anxiety, diarrhea, and vomiting. Those aren't super common, but they're common enough that sometimes folks really don't end up taking them because of it. And the contraindication is severe renal impairment. It really has to be quite severe. So it would be okay to perhaps initiate this medication without some laboratory data, but generally that's recommended, but not 100% necessary. Usually when your patient has severe renal impairment because they have other signs. So that's a camprosate. I don't use it a lot. And I'm limited by the 3 times per day. And I'm also limited by the fact that, kind of like with other medications, like any hypertensive medication, sometimes people don't necessarily feel better when they take it. You don't always notice that you're not drinking as much. You don't always notice that you're not craving alcohol as much. There's a lot of other stuff going on in that early recovery period. So, again, I started becoming an addiction doctor when I was treating patients for opiate use disorder with buprenorphine. Folks feel better very quickly when they start taking buprenorphine, and when they stop taking it, they feel bad. So there's a fair amount of medication adherence there. So with camprosate, it's a little harder to get folks buy-in, especially if it's a 3 times a day medication. Whereas other 3 times a day medications like gabapentin, might be more rewarding because it treats pain or anxiety. Folks feel different when they take it. All right, naltrexone is the next one. Usually give somebody 50 to 100 milligrams a day. You can also give them a Vivitrol shot, which is a deep intramuscular injection. And I say deep, it's, when we were rolling this out in my primary care office, there was a lot of concern about, oh gosh, you need a pretty long needle. It's like a relatively large-ish volume for an intramuscular shot, and it does require a little bit extra attention. Once we started doing this, it became pretty routine, and it wasn't that big of a deal. It was not all that different from a gluteal tetanus shot or Rocephin shot or something like that. But it took a minute just to make sure everybody felt comfortable with it. And it can be, I just saw somebody the other day who was referred to me specifically for one of these shots. And it turns out she had a terrible needle phobia, especially gluteal shots. The provider who referred her to me didn't know much about this medication and didn't really kind of prep her for that. And when I was going through the risks and benefits and giving her some informed consent around it, she's like, no thanks. So it's just good to know that this is a deep-ish and big-ish shot, and because there really are a lot of people out there who don't feel comfortable with that. But for those of whom can tolerate it, it can be really helpful. It competitively binds to opioid receptors. It's essentially Narcan, but there's the oral form and the intramuscular depot form. It blocks the effects of endogenous opioids on the opiate receptor, and somehow it decreases the craving for alcohol. Our brains are complex and fascinating, and so the opioid receptor has some role in the craving of and reward from alcohol use. Common adverse effects include dizziness, nausea, and vomiting. Um, and then the contraindications are liver failure. So again, you don't necessarily need to do baseline labs for oral naltrexone. Usually with intramuscular naltrexone that is done. Acute hepatitis and other hepatic disease. Again, this has to be pretty severe. And so usually what we'll do is it will start naltrexone. You don't have to have stopped your withdrawal management. You don't have to have gotten through withdrawal. In a camper state, you probably can start it while they're still in withdrawal, but the research supports initiation after withdrawal management is completed. So for the naltrexone, we'll often start it a few days into their withdrawal management episode and continue it after they leave. And I have really mixed results. Some people, it helps them right away. They feel less cravings, they feel more comfortable. Some people get a little bit of headache and nausea. Some people, they don't notice anything. So it seems like there's a subset of folks that really feel supported by this medication. And so it's really the one I reach for first, mostly because I'm seeing most of these patients during an acute withdrawal management episode, and I want to get something on board, and it's a once daily medication. Precautions are you can't use this with other opioids. So if somebody is dealing with an alcohol use disorder and an opiate use disorder and they're on methadone or buprenorphine, or if they're needing opioids for any other reason, that needs to be managed. But it could be considered, some folks could end up getting Vivitrol for alcohol and opiate use disorder, and I've seen a few patients successfully treated that way. All right, so then we've got, and the number needed to treat for that is about 20. Again, not bad, but it's really one okay, pretty moderate quality study that supports that number needed to treat. Disulfiram, or Antabuse, is a medication that if people take it every day and they drink, they feel ill. So it's kind of like a negative consequence of drinking that helps interrupt the activity reward cycle. So, this has pretty limited use. It used to be that we would give this to patients, we'd prescribe it and then it would be dispensed with their methadone. And that would be a way to kind of support folks in taking it every day. Otherwise, folks can just plan and skip their medications for a couple of days and drink. And I find that I don't use this medication hardly ever anymore because some of the regulations around what could be dispensed along with methadone were sort of changed recently, or at least our interpretations of it have changed. So methadone opiate treatment programs are less likely to co-dispense those medications. I find that there are some people that just really ask for it. They really find it helpful. They tend to be a little bit older because I think we were using this medication a little more frequently 15, 20 years ago. And if folks find it helpful, I'll prescribe it. But I don't find that it's helpful for very long, and I don't find that outside of kind of a controlled environment that it's all that helpful. It may be something to consider, like in a nursing home or a group home or some place where folks' medication administration is being supported. And then you also have to do some periodic liver labs. So Topamax is something to think about. It seems to act on the glutamate receptor, and it has a fair number of possibly adverse effects, but we use Topamax quite a bit. We use it for migraine prophylaxis. We use it for some psychiatric indications, some seizure indications, but it's not that effective in treating alcohol use disorder. However, gosh, if you've got somebody with migraines and alcohol use disorder, it may be worth seeing how it's helpful in supporting somebody in quitting drinking. Unfortunately, some things that aren't as helpful are gabapentin. And again, I find that, if I'm prescribing gabapentin for another indication, sometimes people are like, hey, you know what? I don't really want to drink when I'm taking this medication. But it doesn't seem to be helpful kind of broad swath. And I feel like that's kind of the case for a lot of these medications. There's like individuals who really, it's a perfect match. And some folks for whom it just doesn't really help, or they don't really notice it helping. And then some folks who it hurts, they have some of these adverse effects on that column. Um, and I think that's partly because there's just some genetic variability we probably don't understand in folks' brains and nervous systems. All right. I want to focus the rest of my talk today on ambulatory alcohol withdrawal management. Um, it was common for me in my practice, and it is common for me to receive folks at Hooper, at my withdrawal management program that I work at, whose primary care providers, it was common for me to do this as a primary care provider. And so what I'll see is that somebody will come in to Hooper and we'll talk to them, and they'll have a handful of Librium, or we'll have a handful of Ativan, a handful of something that their primary care provider has prescribed to them, or an ER doctor has prescribed to them, or they've gotten from the hospital when they left to support them through withdrawal. And it looks all different kinds of ways. I mean, when I would do this in practice, I wasn't ever really sure what to do. And so I would just kind of do something that seemed safe. And the good news is that we don't have to sort of muddle our way through this process anymore, because we have guidelines now. And the guidelines are presented to us by SAMHSA, and they were released early. They were supposed to come out later this summer, but they were released early because of COVID, because everybody started thinking, as we were telling people to stay out of doctors' offices, gosh, what are folks going to do if they're in withdrawal with alcohol? How are we going to support them? So it became a really important kind of urgent issue. So I'm going to give you a case. We've got a 40-year-old woman. She showed us up to Hooper. She's drinking 2 bottles of wine a day. She started drinking when her outpatient treatment went remote, and she had less in-person contact, less human connection, and less accountability. When she showed up to Hooper, her CWA was 12. That's about when I'd give her, based on our protocols, I'd give her like 25 milligrams of Librium, or 50 with that. She lives with an elderly mother, and her mother has COPD and is oxygen dependent. And her hope is she's working with her child welfare caseworker, because she wants to leave withdrawal management, go into a foster care program where she can parent her child. That's the plan. She's well supported in that. She's got the support of her intensive outpatient program. She's got the support of her child welfare caseworker, and she's ready to get that going. So we admit her, and pretty shortly after we admit her, she's got a fever of 101. She's got a mild sore throat. We've got an open milieu at Hooper. We don't have any place to put somebody behind a closed door in isolation. And our policy and procedure is that if somebody becomes febrile, even before COVID, we send them out for evaluation. And now during COVID or flu season, if they have a respiratory disease that might be infectious, we keep them out until they're a little better. So we sent her to urgent care, and she got a COVID test. And this was a few weeks ago, and the COVID test is going to take 3 days to come back, the longest, hopefully a little shorter, but 3 days. So this is somebody we were really interested in supporting. She had a lot of social support. She had a full, assessment from us. She'd gotten to urgent care and gotten evaluated. She did not have an active pneumonia. She did not have any serious indications, significant illness from whatever this infectious disease was. But we couldn't welcome her back because as long as she had a pending test, we needed to know what that test was before we brought her back into our milieu. So here's the ASAM clinical practice guideline on alcohol management. It has draft watermarked all over it. Don't let that concern you too much. It will probably end up being, finalized, but they released it early so that we could use it. And I just wanted to make sure you knew that my associate medical director at Hooper, David Lawrence, prepared the following slides. He was very generous in allowing me to borrow them. He's a really good slide maker, so I appreciate that so much. All right, so one of the things that this ambulatory withdrawal management protocol does, most importantly for us, is to help us understand who's appropriate for ambulatory withdrawal management. I think that was something that I always struggled with when I was seeing patients in my clinical practice. I didn't really know what to tell people. I didn't have a sense of like, oh, you're drinking this much. Like, I think I can do this on my own with you in an ambulatory setting, or not. So that's what the ASAM guidance really helps us kind of get grounded in. So you see our little teeter-totter there in the middle of the slide. So what we're balancing is the risks of undertreated or overtreated withdrawal, because one of the things that we do in withdrawal management, the most important thing is we make sure they're not too sedated, and we make sure that they're not undertreated and they're going to seize. And then we're also weighing the benefits of less restrictive withdrawal management, and that a patient may say, I don't want to be here at Hooper. I've got a lot of support at home. I haven't been drinking that long. I've got lots of social support. That person is likely to do a little better than somebody who has no social support and maybe even, a setting, a home-like setting that is not supportive at all, or like actively triggering. So things that we look at is we say, okay, how much are you drinking? If somebody is drinking 17 plus daily standard drinks, it probably is going to be relatively complicated managing their withdrawal. Not always, but most likely. So that's kind of a cutoff that they introduced in this guidance. Are they using other substances, especially benzodiazepines? That can really raise the risk. And then what's their recovery capital like? That's a term we use, like, do they have transportation? Do they have family or friends that are supportive, both logistically and emotionally? Are they really like cooperative, committed, reliable? Or are we managing their withdrawal like in a single room occupancy hotel where all their neighbors are drinking actively, and or even worse, like are they houseless or couch surfing, or are they living with a group of folks that are are they in an unhealthy relationship, etc. We also look at their comorbid medical issues. Are they, do they have other issues that really are destabilizing? Do they have cognitive impairment? This is kind of a complicated process. So are we able to really work with them, or do they have some cognitive impairments? Do they have a head injury? It's pretty common for folks to come in and be injured in ways that they don't always remember well. Can they take oral medication? Are they vomiting? Are they pregnant? Do they have other reasons to be in the hospital? So after we look at the comorbid medical issues, we ask them, how has this gone for you before? Have you seized before? How did your withdrawal go? I often have the benefit of being able to review that. If this is somebody who did really well with 3 to 4 doses a day of Librium for a few days and then they really got better, great. That's pretty reassuring. Is this somebody who just had a tumultuous withdrawal process and maybe ended up in the ER, maybe even ended up in the ICU? That's helpful information. That's likely to recur. Who isn't appropriate? So these are some more things just to really consider, because folks that can't meet these criteria or these conditions may not be appropriate. So it's really important to support folks, give them a follow-up schedule, daily or calls or in person. Can you provide that? Is that something you can provide? Is it a Friday and are you about to go out of town? And is your partner, your practice partner thinking, telling you like, oh man, I don't really feel comfortable with this. I don't want to cover this for you. Those are things to think about. Those are realities. We can't always meet people's needs exactly the way they need for a variety of reasons, and that's okay. I mean, you just have to really have an honest assessment of that. Do they have the possibility of creating a low stimulating, reassuring environment? Like, can people provide that for them? Do they have the ability to like get some non-caffeinated drinks to hydrate themselves with? Can you give them a multivitamin? Will they take it? Um, will you give them other medications like naltrexone, camprosate, gabapentin? Not super well supported, but sometimes folks, really find it as a helpful adjunct for getting through their active withdrawal management episode. Do they have treatment resources you can connect them with? Do they have mutual support resources that they find helpful? And then usually we recommend daily, in-person, could be virtual, monitoring for about 4 or 5 days, looking into all these things. We give them something called a SAWS, a subjective alcohol withdrawal scale, and I usually give them a sheet of paper and we review it together before we send them home. And so then when you're talking to them or seeing them in person, these are reasons why you might need to send them to a higher level of care. Syncope, worsening psychiatric conditions, vomiting, hallucinations, confusion, seizure, agitation, tremulousness. You want them to, probably be uncomfortable, but generally coping well. Turns out there's some medications that you can offer that are not benzodiazepines, which can be really great for patients and for you, because if somebody's drinking a little bit less and if their withdrawal is more mild when you're evaluating them, you can give them carbamazepine or gabapentin monotherapy, which is awesome because that can be less risky overall for them. But if you're thinking that they might be getting worse, or if they already are worse, then you're probably going to want to give them either benzodiazepine monotherapy or benzodiazepines plus carbamazepine. And the good thing, I didn't include a slide that gave you every single option for all of these things because it summarized it beautifully in this guideline, and I'll make sure that you have that for a reference. And I just wanted to make sure you knew that some folks will really need some benzodiazepine monotherapy. Some folks would benefit from benzodiazepines plus either gabapentin, valproic acid, or carbamazepine. The gabapentin helps reduce the amount of benzodiazepines folks use, and the carbamazepine and valproic acid reduce seizure risk. Gabapentin may as well, but that's less well supported. And then for folks that are less ill, sometimes they do great with carbamazepine or gabapentin monotherapy. That's something that we use a lot if people are kind of almost all the way better from their alcohol withdrawal, but they want to leave Hooper. So sometimes what'll happen is if I'm on call, I'll get a call from the nurse saying like, Mr. Smith is on day 4. He hasn't required more than a dose of Librium twice a day for the last couple of days. He's doing a lot better, but we just don't consider him medically stable, but he wants to leave. Sometimes I'll give them a few days of carbamazepine or gabapentin monotherapy with some, instructions on how to return if they need to. So I'm going to continue with my case. So our patient went to her mom's house, isolated herself in her room, which, wasn't ideal. Ideally, she would have some support, but remember, her mom was oxygen independent, not well, and this person was at risk for COVID. We made sure she had some phone recovery support. She had some counselors and some peers and a sponsor she could reach out to. I started her on chlorodiazepam epoxide QID. Her CEWA was elevated enough. I was a little worried, and I also could see from a prior episode that she needed at least that much the first few days. I actually called her twice a day. So that's a little more than you are really encouraged to provide somebody with if they're appropriate for outpatient management. But I felt like she was kind of on the borderline. I was worried about her, especially her isolation. She did okay for about 24 hours, but she was struggling. She was uncomfortable. She was anxious. Um, and then the good news is that in about 36 hours, her upper respiratory symptoms resolved and her COVID test came back negative. So she had like an isolated fever and a slight sore throat that resolved. And that can happen in withdrawal management. People can have elevated temperatures, but in these, uncertain times, we can never really assume that. We have to make sure that we're keeping everybody safe. Um, so I think it was evening time when her COVID test came back negative. I talked to her and I said, "You've been kind of struggling. I want you to feel comfortable coming back in the morning if you need to. If I don't see you in the lobby at Hooper at 7:30 when most people present, um, I'll just give you a call." And she showed up in the lobby. She was there when I got there, and she had been drinking, I think, for a few hours prior to coming in because she just felt too uncomfortable. So we brought her back to Hooper for withdrawal management a few hours after the first drink she had. Um, and we got her safely through and got her to a residential program, and she's there right now. So, kind of a good example of sort of how we nimbly get somebody to and from the appropriate level of care. So, what you can do is you can say, all right, let's look at the ASAM criteria and let's clarify together, um, the ASAM guidelines, and let's clarify together who we feel comfortable managing as an outpatient in an ambulatory setting and who we don't. And that's going to be kind of dependent on your organization. Do you have capacity to call somebody daily? Do you have capacity to provide somebody with like that level of um, education and support? Um, and then use virtual or telephone visits to minimize the burden of frequent follow-up. It worked really nicely with that patient. We had really fruitful clinical conversations. I felt like I had a really accurate sense of where she was at. And we're all getting better at this, in these times. You can also use gabapentin and carbamazepine withdrawal management protocols, either monotherapy or adjuncts. And the guideline tells you exactly how to do that. And if somebody qualifies for monotherapy, that's awesome because then you're not sending them home with a benzodiazepine, which might make you feel kind of anxious, which would make me feel kind of anxious sometimes. All right, there we have it. Thank you so much for listening to me in this way that we're educating folks in this remote times. And I look forward to doing some Q&A with you later on. So thank you so much.